Our next speaker is Dr. Filippo Pietrantonio. I invited Filippo, because now we're on first name basis, way back in the spring after having been on a virtual conference and listened to him speak about the work and the research that he was doing. And I was just so impressed and so excited about what was going on. And then Katie and I talked about the possibility of, having someone, come and speak about what was going on in Europe and in Italy. And so we agreed that we would invite him, and thankfully he said yes. Dr. Pietrantonio is a staff physician in the medical oncology unit at the Fondazione IRCCS Istituto Nazionale dei Tumori in Milan, Italy. He is a clinician and cancer researcher focused in gastrointestinal cancers, mainly colorectal and gastric cancer. Thank God for us, with particular focus on the design of academic clinical trials and translational medicine. He collaborates with several academic institutions worldwide. Dr. Pietrantonio's research experiences include several phase 1, 2, and 3 clinical trials agents in colorectal and gastric cancer. He devised and conducted several no-profit studies, many of which have resulted in major publications with a significant impact on improving clinical practice. He has written widely on oncology, including more than 200 peer-reviewed articles. Dr. Pietrantonio.
So, hi everyone, thanks for the kind introduction. To talk about Europe, we do clinical trials, and I am a member of the Gono Foundation. Gono Foundation is a no-profit organization that is dedicated to the design of no-profit academic clinical trials when the data property of those trials is of the investigator and not the pharma company. Basically, so I just wanted to thank the organizing committee of My Gut Feeling, because they just not following the gut feeling, but also following the dreams. I stole that picture yesterday night, and the screen was just that specific second. So let's review for a bit the newly updated 2022 ESMO, European Society of Medical Oncology, guidelines for patients with advanced gastric cancer. As you can see here, first-line treatment, biomarker testing is important. First of all, we have to test for HER2, a receptor, and this is important to guide the addition of a anti-HER2 monoclonal antibody to chemotherapy. Trastuzumab chemotherapy was the standard of care for more than 10 years, but nowadays the use of trastuzumab chemotherapy and immunotherapy is reimbursed in the United States by the FDA. This is based on the preliminary results of the Keynote-811 trial, but this treatment is still not reimbursed in Europe, pending the final survival data of this trial. So when HER2 is negative, what we do is test for another receptor, PD-L1, and this is important for the addition of immunotherapy, in particular nivolumab, to chemotherapy in patients with HER2 negative disease but PD-L1 positive disease, assessed with a specific score, the combined positive score that should be more than 5. So this is the standard of care. But what we can do for those patients with negative HER2 disease, negative HER2 and PD-L1 in the disease. So basically, we have chemotherapy. doublet with fluoropyrimidines and oxaliplatin in the first line. And in second line setting, after failure of first line, we have another chemotherapy agent, paclitaxel, plus the anti-angiogenic agent ramucirumab. This is the standard of care. And this is why, for this particular subset of patients, we have to improve the strategy and the use of this agent to improve patients' care. And this is why we designed the Armani trial. As you can see, this is a phase 3 multi-center randomized trial done in Italy. Armani is an Italian designer, and the trial is sponsored by my institution. As you can see, which is the background of the study. Unfortunately, a still relevant fraction of patients with metastatic gastric cancer will not be able to receive, after progression to first-line therapy, an active second-line treatment that is potentially able to improve and prolong their survival. This is because they're too sick, because of rapid progression, performance status decline. So the aim of the study is to evaluate an early second-line treatment with paclitaxel and ramucirumab in these patients with the aim to expose to all potential active agents the highest number of patients. And as you can see, the trial enrolls patients with HER2 negative disease, with disease control, so no progression after 3 months of standard first-line therapy, oxaliplatin and fluoropyrimidine. And then there is a randomization between the standard strategy, so continuing the same chemotherapy regimen, versus experimental strategy in red, so switching to a non-cross-resistant maintenance. The target accrual of the trial is almost reached, 280 patients, so we will have soon the results of this study. We have novel targets for personalized therapy for patients with advanced gastric cancer. Here you can see the most promising one, FGFR2b, fibroblast growth factor receptor 2b, is selectively expressed on the tumor cells and not in the normal cells. And this is targeted by another monoclonal antibody, which is bemarituzumab. On the right, you can see Claudin 18.2. Claudins are very important for the thigh junction in the stomach to protect the gastric wall from the acid in the stomach. And as you can see, usually Claudin 18.2 is a molecule that is buried in the junction. But after malignant transformation, so loss of polarity in the tumor cells, this antigen, this protein is exposed on the surface of the tumor cells, so it becomes a target for potential treatment. And this is why zalbetaximab, another monoclonal antibody, was designed. Basically, for these two agents, we have a companion diagnostic, which is immunohistochemistry. So tumors should be tested for the expression of both FGFR2b and Claudin 18.2. And immunohistochemistry helps us to define the intensity and the extension of the marker expression. As you can see, it is classified as 0, 1, 2, 3 plus, according to negative or weak, moderate, or strong staining. And to define a positive FGFR2b tumor, at least 10% of the tumor cells should show moderate or strong staining expression. And to define positive Claudin 18.2 tumor, at least 75% of tumor cells should show overexpression of the target. So there are now ongoing trials because these biomarkers allow to amplify the benefit of adding these new agents to chemotherapy. So now these trials, phase 3 trials, select patients based on the expression of the target. So we have two trials for bemarituzumab, Fortitude-101 and Fortitude-102. The first one is evaluating the addition of bemarituzumab to standard chemotherapy. And the second one is evaluating the addition of bemarituzumab to standard chemoimmunotherapy, so chemotherapy plus nivolumab. For what concerns zolbetuximab, we have again two trials, Spotlight and Glow, that are evaluating the addition of zolbetuximab to chemotherapy with either FOLFOX or CAPOX. And we have news because there was a press release 2 weeks ago showing that Spotlight is a positive trial. So we will soon see the results at an upcoming meeting, probably in January, showing that zolbetuximab is able to increase patient survival when added to chemotherapy. So we're really waiting to see the results and to have this new option for our patients. Another frontier is the use of antibody drug conjugates. As you can see, these are monoclonal antibodies directed against a specific receptor, but they are also linked to a payload, which is usually a chemotherapy agent. As you can see on the right, these agents are able to do a targeted delivery of chemotherapy to the tumor cells, sparing normal cells. And for HER2-positive disease, we have trastuzumab deruxtecan, a new agent that is targeted against the HER2 receptor. And we have now data on the potential efficacy of this agent and two trials, Destiny Gastric 01 and Destiny Gastric 02. The first was done in Asia. The second one was done in North America and Europe. As you can see, the results are quite similar, and more than half of the patients responded to this treatment despite prior failure of trastuzumab. We had complete responses, as you can see on the right, with this novel agent. And this is really important because complete response in metastatic disease, of course, doesn't necessarily mean cure of the disease, but is important if you want to translate the use of this agent in patients with early resectable gastric cancer. So this was again approved in Europe 2 weeks ago, so it's an exciting period for patients with gastric cancer. And hopefully the confirmatory phase 3 trials will lead to reimbursement in each country. So let's now talk about early stage disease, because this overview was just done to let you know what's going on, which are the new potential and promising agents in the disease. But what we can do as academic researchers is much more focused on patients that have a curable disease and can achieve a complete eradication of the disease. So let's review again the 2022 new ESMO guidelines for resectable gastric cancer. As you can see, for all, with the exception, of early stage gastric cancer, for all patients with CT2 or more, independently of nodal status, perioperative chemotherapy is recommended. For emergency surgery, for perforation, severe bleeding, upfront surgery in emergency is needed, so adjuvant postoperative chemotherapy may be recommended, but usually we give 2 to 3 months of chemotherapy before and after surgery. And nowadays, the standard of care for fit patients and younger patients is the triplet chemotherapy with the addition of a taxane, docetaxel, to fluoropyrimidines and oxaliplatin, which was the previous standard. As you can see in the survival curves of the of the phase 3 trial done in Germany, FLOT regimen was able to provide a gain of overall survival in this population. But we also must be aware that despite surgery, multimodality treatment, the outcomes of our patients are still poor, and most of them will have disease relapse, usually within 2 to 3 years, but late relapses are also a possibility. So there is a lot of room to improve these outcomes. And how can we do that? By using novel agents and improving the strategy we use to treat these patients. So first strategy is this one. After preoperative chemotherapy and surgery, the patient may be cured, but there may be minimal residual disease. This is called micrometastasis. In the future, this micrometastasis will lead to disease recurrence. But in case of effective adjuvant postoperative therapy, we can eradicate micrometastasis and minimal residual disease, and this can still lead to a complete cure of the disease. So it is not possible to identify micrometastasis with standard radiological imaging. So we can estimate the risk based on classical pathological factors such as nodal status and TNM staging. But anyway, we will talk a little bit later about the role of liquid biopsy to precisely detect minimal residual disease. But this figure is really informative, in my opinion. You can see in green patients that were cured just by preoperative chemo and, of course, surgery, which is the mainstay of treatment. These patients have negative minimal residual disease after surgery. In yellow and red, you can see patients that were not cured by surgery, with or without preoperative chemo, so they are minimal residual disease positive after surgery. But those in yellow can still be cured by effective postoperative therapy. The fraction of these patients is really low if we continue the same treatment given preoperatively, so continuing FLOT after being MRD positive after preoperative FLOT. But this proportion can be relevantly increased with a switch to an alternative regimen, which is non-cross resistant to chemotherapy. So this is the rationale for the design of new trials, and this is the design of Vestige trial done by the ERTC in Europe. As you can see, this trial enrolls patients who completed their treatment, preoperative chemo and surgery. And after surgery, these patients are randomized to either continuation of chemotherapy, which is the standard of care, or dual immunotherapy treatment. Of course, there is a lot of imprecision again in this trial, because this trial will enroll red patients, yellow patients, and red patients, hoping that the yellow ones will be enough to drive a positive result in the overall population, of course. So there is room to better identify those yellow patients and offer them additional therapy, and this is the role of liquid biopsy. As you know, cancer cells release in the bloodstream their DNA, which contains basically gene mutations, gene methylations, and other gene alterations. And the advances of technology allowed us to potentially detect minimal amounts of circulating tumor DNA in the blood. So basically, micrometastasis can be detected in a simple and single blood drawn by applying ultra-sensitive assays. So what to do to personalize postoperative treatment? First thing is use liquid biopsy to improve risk stratification beyond classical pathological risk factors. So to identify patients that will really need additional therapy. And then after postoperative therapy, liquid biopsy can allow us to monitor the treatment efficacy. So, for example, negativization of circulating tumor DNA can be a proxy, a surrogate of clearance and eradication of minimal residual disease and prevent subsequent relapses. So we have two different possibilities, several assays to detect minimal residual disease, but two main categories. The tumor-informed assay is based on the sequencing of the tumor, and then a personalized assay is built for every single patient with the mutations, its mutations found in the tumor, in the specific tumor, and used for the blood testing. For plasma only, or the agnostic procedures, we use assays and panels that contains multiple recurrent mutations typical of cancer or specific cancers such as gastric cancer. There are advantages for tumor-informed assays, especially higher sensitivity. Usually we can detect more patients with minimal residual disease, but the turnaround time is higher because we need to collect the tissue, analyze the tissue, then build the personalized assay and test the blood of the patients. Plasma-only assays have, of course, lower sensitivity, but they are more easy to use, and they have a shorter turnaround time. So there is a lot of effort to increase the sensitivity of these assays too. So by combining all together, so biomarker-driven treatment in the adjuvant setting and liquid biopsy-guided identification of patients that need additional therapy, we designed this trial, which is called Trinity, and it's sponsored by the Gono Foundation. As you can see, this trial enrolls patients with resectable gastric or gastroesophageal junction cancers with HER2-positive disease status and eligible for perioperative chemotherapy. These patients will receive 4 preoperative cycles of FLOT, the standard regimen, and then surgery. After surgery, MRD, minimal residual disease testing, is done. So those with negative circulating tumor DNA will continue the same chemotherapy regimen. Those with positive ctDNA, circulating tumor DNA, will be offered the possibility to be randomized to the new agent, trastuzumab deruxtecan, which is the antibody-drug conjugate that we saw earlier in the presentation. The primary endpoint of this study is ctDNA clearance. So we will look at 1 year after treatment if a higher proportion of patients treated with the experimental strategy will be cleared of the ctDNA compared to those continuing chemotherapy. So last part, I will focus on a specific subtype of gastric cancer, which is microsatellite instability high gastric cancer. This is usually a sporadic type of gastric cancer, but it may be also hereditary and related to Lynch syndrome. As you can see, the prevalence of microsatellite instability is relatively high in gastric cancer, probably 9 to 15% of patients, and it is only second to endometrial and colorectal cancer. Usually these patients are female, older age, enteral localization, low grade of differentiation at histological examination, and intestinal isotype, usually N0 disease at pathological examination. Typical of this tumor is the high lymphocyte infiltration in the tumor, so these tumors are really highly immune dependent. And this is important because we will see the results of immunotherapy in this particular subset of gastric cancer. We did a large meta-analysis of 4 phase 3 trials done in Europe and in Asia. And as you can see, we collected more than 1,500 patients with, and 9% of them had microsatellite instability, 90% of them node-positive disease. As you can see, we confirmed that patients with microsatellite instability have excellent outcomes with a long-term survival that is clearly higher than patients with MSS disease. You can see MSI in blue and MSS in red. We also analyzed the impact of adding chemotherapy to surgery in this particular subset, and we saw that there is a clear benefit of adding chemotherapy in MSS subgroup, but no such an effect in MSI. As you can see, the yellow line represent patients treated with surgery plus chemotherapy and MSI high status, microsatellite instability status. So this particular subgroup of patients could be considered relatively chemoresistant as compared to others. But what we know more recently is that these patients are hypersensitive to immunotherapy. This data comes from metastatic disease, and 2 different meta-analyses, one from my group, one from Asia, showed the same, that immunotherapy compared to chemotherapy alone is able to cut the risk of death by 70%. So now this is the standard of care for all these patients. How to bring immunotherapy in early stage disease in patients with resectable disease to further improve their outcomes. So the companies, pharma companies, are doing phase 3 trials in all comers without selecting for microsatellite instability or for any biomarker, with the philosophy of one size fits all. But we know that these tumors with microsatellite instability are quite different from the others. So we need trials specifically dedicated to this small subpopulation of patients. So France come to help us, and this is the design of the NeoNIPIGA trial. In NeoNIPIGA trial, 32 patients, the frequency of patients with MSI high tumors is low. But anyway, patients were treated with dual immunotherapy regimen for 3 months and then resected. What happened is that in 60% of them, the tumor had disappeared. So there were no viable tumor cells after resection in their tumors. Why is this important? Because this opened the ways, clearly, to new studies with non-operative management strategies. We've been talking a lot all day long about what is for patients with gastric cancer facing gastrectomy, living without stomach, and facing weight loss, malnutrition risk for them and for their caregivers. So for this particular subset of patients, let me underline, these are few patients, very selected patients. There will be trials dedicated to avoid surgery, not just chemotherapy, but avoid surgery, thanks to immunotherapy. So that's what we did in Italy. So this is the Infinity trial design. As you can see, there are 2 cohorts. First cohort, we give immunotherapy and then resection. We have analyzed the final results of this cohort, and it's pretty consistent with what we saw with the French study. Again, in Italy, we saw 60% of complete tumor disappearance with immunotherapy. But we didn't stop here, so there is a second part, a second cohort that was just started. And what we do here is to give the same 3-month immunotherapy treatment to these patients, and then reevaluate with every possible examination to identify patients that are in complete response. We use radiological imaging, PET scan, we use endoscopy, endoscopic ultrasound, biopsies, and liquid biopsy for minimal residual disease testing. 5 things together to be sure that there is no left tumor in the tumor bed. And then these procedures are repeated intensively. So this is stressful for the patients that will choose to try to save the stomach, but every 3 months, we will do the same examinations up to 2 years. And here the primary endpoint will be the rate of complete response without salvage gastrectomy, which is always an option in case of tumor regrowth during this intensive follow-up. So for this particular trial, we had support of the Italian advocacy group, which is called Live Without Stomach. And it was really nice to work with them because I said, okay, you're supporting a trial where we aim at living with the stomach. So thank you very much. And this is my research group in Milano.